Diksha and you are watching DEATHWATCH Media channel. Let's take a look at today's headline. DEATHWATCH community impacted with unknown virus. People are living under fear, so here's the update from the community.
We have been attacked already. These viruses, this must be spread by our enemies. I have to do something. It has already took a lot of life. We have lost our warriors. I can't let it spread in our whole community. I have to do something. I have to do something. I have to call my investigating team. They are my now. Did you hear the news already? We have been attacked. Yes, I got to know. It seems like a deadly virus, It spreads so fast. We have to do something about it as soon as possible. We really need to do something. It has already took a lot of life. We need to do something. Yes, Chief. We will put our full doctor's team behind this and we'll find the diagnosis and the proper treatment about it. You don't worry. We got this and we'll do this and we'll end it soon.
General data: AB was a 48-year-old male residing in Zorzor, Lofa County, Liberia. Chief complaint was behavioral changes. History of present illness: 28 days prior to admission, he developed pharyngitis and low-grade fever. 1 day prior to admission, he is complained of nausea and vomiting with 3 episodes of loose bowel movement. 3 days prior to admission, he developed behavioral changes, and at the time of admission, he was noted to have fever, double vision, slurred speech, and jerking in his left arm. There is no history of previous hospital confinement or surgery, and there is no known hypersensitivity reaction to any food or medication. Family medical history: it includes hypertension, cardiovascular diseases, pulmonary TB, cancer, and pernicious anemia. Personal history: patient smokes 7 sticks of cigarettes since he was 18 years of age. He drinks at an average of 3 bottles of beer daily. He has strong preference for bush meat, mostly antelope, and prefers eating it raw to slightly cooked. Review of systems: there was loss of appetite and fever. There was headache and difficulty swallowing. In neck, CVS, and gut system, there was no abnormality. In musculoskeletal system, there was muscle pain. In endocrine and hematology, there was no abnormality except dysphagia. In neurological system, there was no loss of consciousness, but there is behavioral changes. Chest X-ray appears to be grossly normal. The chest X-ray lateral view also appears to be grossly normal. In ECG, which is suggestive of right bundle branch block, right axis deviation, inferior wall myocardial infarction, and sinus rhythm appears normal. Physical examination on admission: patient was awake but anxious and disoriented and in cardiorespiratory distress. Vital signs was BP 160 systolic and 100 diastolic mmHg. Cardiac rate was 120 beats per minute. Respiratory rate was 40 cycles per minute. Oxygen saturation was 95% and temperature was 38 degrees Celsius. Height was 170 centimeter and weight was 80 kgs. The head, eye, ear, nose and throat examination, neck, chest and abdomen examination was found to be normal. In heart examination, the heart was found to be tachycardic, regular rhythm and no murmurs. In extremities also, there is no abnormalities found. In neurological examination, all the cranial nerves were intact, and in sensory examination, the patient withdraws when pressure and light touch is applied to all extremities. There was no Babinski response and normal deep tendon reflexes. Now the blood exam result. First, the CBC examination. The levels of SCT, MCV, MCH and MCHC was appeared to be decreased, and the levels of RDWCV and eosinophil percentage was appeared to be increased. In coagulation studies, the patient's APTT was appeared to be high. In blood chemistry examination, the glucose, creatinine, magnesium, phosphorus, AST, LDH and globulin was appeared to be increased, and the sodium chloride and albumin was appeared to be low. In CSF exam result, the glucose level was appeared to be normal, and the WBC protein, RBCs and ALT was appeared to be high.
Features: AB, a 48-year-old male residing in Zorzor, Lofa County, Liberia. He had behavioral changes. There was pharyngitis and low-grade fever noted. Nausea and vomiting were also noted. There were 3 episodes of loose bowel movement. He became agitated and refused to eat and take bath. The patient had fever, double vision, slurred speech and jerking in his left arm, loss of appetite, headache, muscle pain and dysphagia. There was hypertension noted and patient used to smoke. The patient was tachycardic. He used to drink alcohol. He gave preference for bush meat, mostly antelope, eating it raw to slightly cooked. He had microcytic anemia. Glucose, creatinine, magnesium, phosphorus, AST and LDH are increased. Globulin is also increased. Sodium, chloride and albumin is decreased. In CSF, glucose is normal. Protein, RBC and WBC are elevated and ALT is mildly elevated. Initial impression. Initial impression is Ebola. Ebola virus disease, formerly known as Ebola hemorrhagic fever, is rare but severe and often fatal illness in humans. The virus is transmitted to people from wild animals and spread in human population through human to human transmission. Signs and symptoms are fever, fatigue, muscle pain, sore throat, vomiting and diarrhea.
Hello everyone. So now let's see the possible differential diagnosis of this case. So our first differential diagnosis is a trichinosis. Trichinosis, also known as trichinosis, is a disease that people can get by eating raw or undercooked meat from animals infected with the microscopic parasite that is trichinella. So our rule in are fever, myalgia, headache, diarrhea, abnormal neurological examination that is altered level of consciousness, fatigue and malaise. And our rule out are palpebral edema, hypereosinophilia, urticaria, CHF and encephalitis. So our second differential diagnosis is Creutzfeldt-Jakob disease. So CJD is a rapidly progressive, invariably fatal neurodegenerative disorder which is believed to be caused by an abnormal isoform of a cellular glycoprotein which is known as prion protein. So our rule in are headache, dysphagia, jerking muscle, personality changes, hypertension and fatigue, and our rule out are insomnia, dementia, blurred vision and apathy. Our third differential diagnosis is echinococcus. So human echinococcus is a zoonotic disease and humans get infected by ingesting parasitic eggs in contaminated food and water. So our rule in are bush meat consumption, fever, nausea and vomiting, and our rule out are biliary obstruction, bloody stools, chronic cough and chest pain.
Our final diagnosis is viral meningoencephalitis secondary to Ebola. Now, moving on to the pathophysiology, our 48-year-old patient from Liberia had been presented with these symptoms prior to the admission to the hospital. The main complaint, or the chief complaint for which he visited the clinic, was behavioral changes. On admission to the hospital, the patient presented with the following symptoms. In his vital signs, it proved that he is tachycardic, tachypneic and also hypertensive. One of the peculiar features which we should note here is that the patient used to consume bushy meat raw or slightly undercooked. So all these features made us to come to the conclusion that our initial impression should be Ebola virus. Now talking about Ebola virus, it is a virus that infects the macrophages in the blood and which triggers, or the proteins triggers the formation of clots throughout the blood, which could ultimately reduce the blood flow to the organs. Now, due to the reduced blood flow to the organs, it has affected multiple organ systems of the body. Starting with the GI, it has damaged the GI cells, which could have led to the diarrhea. Also, the liver has been invaded, which could have led to the increased ALT and AST levels. Also, the renal system is affected, which is proven by the increased creatinine levels and also the abnormal electrolyte imbalances. The adrenal gland has been attacked by the virus, which makes it crippled, and its capacity to control the BP is also being damaged here, so that we could consider it to be having a circulatory failure. At last, when we saw the CSF exam, it showed inflammation or suggested inflammation in the brain. So now, the ECG findings also proved that it is a right bundle branch block, which is suggestive of inferior MI. One more point which should we keep in mind is that this Ebola virus thrives for iron. That's why our patient is here experiencing microcytic anemia, and all his MCH, MCHC, that the hematocrit levels are decreased. But there is increased eosinophilia and globulin level, which suggests inflammation. Now, after the admission to the hospital, the patient presented with neck pain and back pain, which is suggestive or highly suggestive of meningoencephalitis. Another day, on the next day, he also had inability to move the lower extremities, and later on he passed to delirium, stupor and coma. All these included that this patient is having meningoencephalitis, or the inflammation is occurring in his brain. Now, We could also say that as there is reduced oxygen level, the cells have shifted to an anaerobic respiration, which could have probably led to the respiratory arrest and ultimately led to the sad demise of our patient.
Management for the viral meningoencephalitis secondary to Ebola. So treatment algorithm that should have been followed in our case include the criteria for encephalitis of presumed infectious etiology and exclude all other causes. If the viral etiology cannot be ruled out in first 6 hours, we should start with the empirical treatment of acyclovir. After that, etiological investigation for the viral and other infectious causes should be done. If the virus is identified, switch to antiviral if necessary. Report and indicate. Rehabilitation and follow-up should be done. Inconclusive causes should be further investigated by doing CSF, PCR and serology testing. Viral etiology cannot be ruled out complete within 14 to 21 days with acyclovir. The antiviral drug that should be considered include acyclovir, ganciclovir and foscarnet. Supportive care include people who are hospitalized with severe diseases. The breathing assistant as well as the careful monitoring of breathing and heart function should be done. IV fluid to ensure the proper hydration should be given. Anti-inflammatory drugs such as corticosteroid should include for swelling and pressure within the skull. Anticonvulsant medication should be used to prevent the seizures. Cause of death in our patient include immediate cause, which include hypoxia. Antecedent cause include inferior myocardial infarction and underlying cause include Ebola. Thank you for your attention and special thanks to Dr. Acosta, Dr. Ocampo and Dr. Ricciuolo for helping us throughout this CPC.